This is the surgical protocol for Capsulaser selective laser capsulotomy as of January 2023. We're now going to see 4 examples of Capsulaser in action: focusing the laser, centering the laser, and firing the laser. The laser has created a capsulotomy in less than 0.3 of a second, and you can see it's beautifully centered on this enhanced area of staining with trypan blue. And here's the final example. Capsulaser is indicated for use for anterior capsulotomy. The mechanism of action is Capsulaser is a selective laser capsulotomy device that operates through the absorption of the orange wavelength 590 nanometers of laser energy onto a trypan blue stained capsule, converting type 4 collagen to amorphous collagen. You dye the capsule, you focus on it, you apply the laser and get your capsulotomy. Let's now have an overview of reasons to consider Capsulaser. It creates the highest quality anterior capsulotomies, with laser precision in size and circularity, 100% symmetrical 360-degree coverage of the IOL with the capsulotomy in all studies, with a highly tear-resistant edge, and the most accurate capsulotomy centration. There is improved visibility, including centration with capsule blue, and for all stages of cataract surgery, with proven surgical value in complex and premium cases. And it will grow your business with cost-effective premium laser cataract surgery. Capsulaser produces the highest quality capsulotomy with laser precision leading to centration and 360-degree coverage. We did a meta-analysis following a prospective study comparing the results for Capsulaser for centration, accuracy of sizing, and circularity. And we compared these with 10 clinical studies for FLACS and CCC. And you can see how, towards the left-hand side of favorable, there is a distinct advantage for Capsulaser. Centration and symmetrical 360-degree coverage was found 100% for Capsulaser patients, 89% for FLACS, and 72% for CCC done manually. If you look at incomplete coverage, there are certain clinical conditions which are associated with incomplete coverage. Most importantly, early onset PCO and IOL tilt and translocation. The capsulotomy created with Capsulaser has a visible and tear-resistant rim. We studied this by looking at paired cadaver eyes, and we compared Capsulaser with CCC and FLACS. And you can see here in this video the amount that you can extend the edge of the capsulotomy without it tearing. In the study that we did comparing these methods of making the capsulotomy, you'll see that CCC was somewhere between Capsulaser and FLACS. Here's actually a human example where the surgeon Burkhard Dick has chosen to try and stretch the capsulotomy. There's a smooth rolled over edge due to the amorphous collagen that is created at the edge of the capsulotomy by the use of the laser, and this gives increased tear strength. If you look at the relative tear strength, its FLACS is 70%, CCC is 100%, but Capsulaser is 150%. We've published this data and it's significant at P at less than 0.01. Here you can see a scanning SEM example of the rolled over edge of the Capsulaser capsulotomy, which has been deliberately cut. Let's now have a look at the minimal temperature rise which is achieved using this laser. If we look at the 3 sites here, at the edge of the iris, at the cornea, and at the retina, we can see what the peak temperature is, and it only lasts at this level for less than 0.05 of a second. At A, it's less than 0.2 of a degree Celsius. That is similar at B, and at C on the retina, it's less than 0.1 of a degree Celsius. And for reference, 2 degrees Celsius for 1 second is the threshold for thermal effects on sensitive ocular tissues. We measured this with two techniques, IR imaging and thermocouple. Capsulaser is therefore compliant with all ophthalmic instrument standards for safety within the eye, including ISO 15004. We've talked about centration, but what does this mean with Capsulaser in practice? What you can see here in this photograph is a capsulotomy which has been centered on the pupil. What you can see in the middle of the photograph is an area of enhanced staining from the trypan blue, which is also coincident with the first Purkinje reflex that you can see in the middle of this enhanced area of staining. We can see in the photograph below that there is asymmetric coverage of the IOL, which in time as the capsule contracts will possibly lead to the capsulotomy edge going over the edge of the IOL. If you use the Purkinje or trypan capsular landmark, then you can get accurate centration and symmetric 360-degree coverage, as you can see in these examples here. Both of the capsulotomies have been centered on the enhanced area of staining, which is coincident with the Purkinje reflex. And on the right, you can see that both of the capsulotomies are perfectly centered in a 360-degree manner on the IOL. If you start to measure the differences, and we've done a study now comparing 60 eyes with centration on the pupil and 60 eyes with centration on the capsular landmark, then you can see that there is a difference in terms of centration. This graph shows what you can achieve with centration on the pupil, and this one with centration on the capsular landmark and the first Purkinje reflex. And there is certainly a difference. And this is also reflected in the visual acuity which is achieved in these eyes. There is a definite difference here which is significant also. Let's have a look at the preparation of the eye. You're going to do your standard eye preparation, dilating drops, anesthesia, and then make the side ports. Put HPMC on the corneal epithelium to protect the eye from dye. Then do the trypan blue capsular stain. Use the more eye the better, and make sure you use it for 60 seconds minimum, and this really does improve the staining that you get. Then you're going to wash out all of the dye with using 5 milliliters of BSS. Reapply HPMC to the cornea. Then do an OVD backfill. This is a firm backfill with OVD coming out of the incision. And you need to be precise, and if in doubt, repeat the step. Let's get to the alignment and laser next. With the fixation ring, minimize eye tilt. Use the microscope to center and focus using the microscope foot switch. Finalize capsulotomy location and apply the laser for capsulotomy by centering on the Purkinje image or the trypan blue central landmark. Let's have a look at a standard procedure. The pupil is well dilated here and the eye anesthetized. The side ports are being made. They're going to apply some HPMC to the cornea to prevent any staining with capsule blue. Once that is in place, we're going to inject the dye. This is microfiltered trypan blue, and it's very slowly injected. The specific gravity of the dye is greater than that of the aqueous, and therefore it settles onto the anterior capsule. And it should be left there, preferably for 60 seconds. And we'll see why this is later on. Once it's been there for 60 seconds, you can then wash it out, and it's important to do this thoroughly. You do not want to leave any trypan blue in the anterior chamber except for what is stained onto the anterior capsule. Here we can see it's starting to be removed fully now, and the central trypan landmark is starting to appear. A little bit of a wash, and you can see it much more clearly. We're now going to put some HPMC on the cornea again. And once that's in place, we're going to backfill the anterior chamber with an optically clear OVD. It's important to do a backfill rather than filling up from near the side port. And you want to see OVD overflowing from the side port. Next, we're going to turn on the focusing and centration beams and place the fixation ring on the eye. Once you've done this, you focus the laser and center the beam on the trypan feature that you can now see. And once that's in place, depress the foot pedal and fire the laser. A well-centered intraocular lens with symmetrical 360-degree capsular coverage is now seen. So let's go through things in a little bit more detail. First, we'll have a look at the trypan blue capsule stain. Apply HPMC to the cornea before the trypan blue to avoid inadvertent staining of the corneal epithelium. The trypan blue stain is put in with a low and slow motion technique, and the cannula is placed on the capsule and use the majority of what's in the syringe. Or if you're using the air bubble technique, then refer to our suggestions you'll see in a moment. Give it 60 seconds of staining time. The goal is to get an intense stain which is 3 times that of a standard trypan solution. And note, with slow motion technique, bubbles can cause non-uniform staining. It's best to remove bubbles, or even better, prime the cannula. Here we can see a graph comparing stain intensity with capsule exposure time. At the top we have capsule blue, and you'll see that in 60 seconds there is very intense staining. With vision blue or generic trypan blue, you get nothing like this intensity of staining, despite a length of time spent in the anterior chamber. Let's have a look at the slow motion technique compared to a fast injection. This is in a bottle containing BSS. The dye is being injected slowly, and you'll see that it stays together and it descends right to the bottom of the jar without coming significantly apart. And this is why you're going to get good staining in the anterior chamber when you inject it in this way. Following landing on the bottom of the jar, an injection will be done quickly, and you'll see what happens here. There it is now, it's settled beautifully. It's now spreading out on the bottom of the jar. If you inject rapidly, it certainly goes into the jar, but what happens is that it gets a very significant dilution, and therefore it doesn't stain as well. What about the backfill? The purpose is to overfill the anterior chamber and to use it to remove all the BSS from the anterior chamber. This will also flatten the anterior capsule and make the laser work more efficiently. The technique is to place the cannula 80% across the anterior chamber, keep the cannula stable in the OVD, and let the OVD expand and firmly fill the anterior chamber, and then gradually withdraw the cannula whilst injecting. If there are optical inconsistencies with a worm-like appearance present, continue to fill so that these disappear. Overfill to the extent that the OVD exits the incision. Now let's have a look at some of the Capsulaser approved anterior chamber OVDs. You can use Capsule Visc 2% or 3%, Alcon Viscoat or Disco Visc, and from Johnson & Johnson, Helon Endocoat and Helon Pro, but you mustn't use HPMC, Ordinary Pro Visc, Helon Pro or Helon GV. Let's see the OVD backfill again. Going across the eye, 80% fill, fill, gradually remove the cannula, wait until the AC is overflowing with OVD from the side port. Now let's have a look at focus and alignment. This is the aiming guidance pattern that you'll see when you turn it on the equipment. This is the target location and size of the capsulotomy that you've already chosen. This is the focusing guide, the 2 red laser beams, which are representing the angulated Purkinje images, and these overlaps at the Capsulaser focus. Here we can see the corneal reflections, the anterior capsular reflection at the top of the lines, and the lines that you see here denote scatter from the natural crystalline lens. The space between the cornea and the capsule reflections represent the anterior chamber depth. How are we actually going to focus? Before the fixation ring is placed, you can see that the way that the dots are arranged, you're focused below the capsule. When you apply the fixation ring with a little bit of pressure, and then focus on the anterior capsule, you'll see that the two little dots come together. But be very much aware that you mustn't treat if there is a gap between these lines, because what this means is that you're focused above the capsule and therefore too close to the cornea. So the warning is mind the gap. Here we can see an aim, a focus, and a fire. The capsule has been stained, the OVD is in place, the fixation ring is on, as is the aiming beam and the aiming device and the focusing device. We're going to pre-warn the patient of a bright flash to remain still, use the coaxial Purkinje image, the trypan capsular feature, fire the laser, and then once you've done that, you can remove the anterior capsulotomy cap. This is easily done just by peeling it off the cortex. So let's have a look at some basic best practices and contraindications. Best practices: you should note that if there are bubbles present in the OVD, as the laser passes over a bubble, it will act like a local lens and cause a tissue bridge posterior to the bubble. This is obviously something you want to avoid. If tissue bridges exist, take care, as these are the weak points of the capsular rim. For centration, use the trypan central landmark or the coaxial Purkinje image, as we've seen. Do not perform a double laser capsulotomy treatment. Rather, perform a manual capsulotomy if things are not the way you want them to be in order to correct any problems. Here are some examples of the trypan central correlation with the coaxial Purkinje image. And you can see how well they act together in the middle of the trypan central feature. Here we can see the capsulotomy centered on the TC landmark with displacement of the coaxial Purkinje image. This means that you get a very nice symmetrical 360-degree coverage of your IOL. However, for patients with endothelial disease, the best practice is to use an air bubble technique, and this is very much the recommended approach with endothelial disease present. Prior to air bubble placement, put some OVD on the incision. This is to stop the air coming out. Create one large air bubble, larger than the iris. Give it a full 60 seconds of wait for the staining, and then wash out all the trypan blue using BSS. 5 mL is recommended. What are the contraindications? The following are contraindications for performing selective laser capsulotomy with Capsulaser. At present, pediatric cases are not indicated. We need to do controlled clinical studies to make sure that there is safety in the smaller eye. Please do not use phenylephrine 10% dilation drops. These are contraindicated because they have the potential to cause corneal shock. Trypan blue can then be upregulated to the endothelium, and the laser may cause damage. All other means of pupil dilation may be used, including midraine, amidria, tropicamide 1%, phenylephrine 1%, and 2.5%. As with all trypan blue uses, patients who are pregnant or trying to become pregnant are contraindicated. And remember that more than one single capsulotomy treatment in the same eye on the same day is contraindicated. There are some instances where physician discretion is required. For corneal disease or pathology such as corneal scarring or partial opacity in the central 6 mm of the cornea, patients with a constricted pupil can be dilated with a mechanical pupil expander. If one is not used, 1 mm pupil clearance is required around the capsulotomy diameter to avoid inadvertent laser exposure of the iris, i.e. the pupil must be at least 6 mm for the Capsulaser diameter setting of 5 mm. If there is lens or zonal instability, unless the surgeon determines that he can use OVD to prohibit migration of trypan blue to the posterior chamber, one needs to be careful. If there's an abnormal examination from the slit lamp or fundus examination or IOL master or topography, then you need to look at this very carefully. Age-related changes, however, are acceptable. But what you see is what you get. And this applies to capsulaser use. Here we're going to see an example of the corneal scar, which has attenuated the laser and resulted in an imperfect capsulotomy, which needs to be manually completed. You can see the scar in the cornea superiorly. It will become much more obvious once we have the dye in place. The dye has been washed out now. You can still see the trypan central landmark, but we'll see what happens once the laser is actually applied. In this particular instance, this was one of the earlier cases and the patient interface in place rather than a fixation ring. But you'll see that superiorly there's an incomplete cut in the capsule. Patient interface is now going to be removed. The cornea has some more BSS put on it. You can see now more clearly where the laser has not done its work appropriately. The main incision is made and the capsulotomy cap will be removed. However, despite the fact that the laser has not done a full cut, you'll see that it is perfectly possible to peel the capsulotomy round. And this is done with microforceps through the side port. And because it's been centered on the trypan central landmark, we have a very nice round capsulotomy despite this issue with the corneal scar. Shortcuts really don't work. You need to be precise at each stage and repeat each stage if necessary. Here we can see an inadequate washout and then OVD not backfilled. Dye has coated the cornea as there is no exit route. You can see the dye also trapped inside the anterior chamber. And this makes the use of the laser unsafe. In this instance, there was a potential for a corneal burn if the laser was applied, and in this case it was completed, or the capsulotomy was completed manually. Here, there's too short a staining time, and this will result in an incomplete capsulotomy, and there is also eye movement. And you'll see what happens if there is insufficient capsule dyeing time. We have got a central landmark, but round about it, the dyeing is not complete. And you can see that you get rather a strange shaped capsulotomy, which is incomplete after the laser excursion. The patient has also moved the eye a little bit at the same time. We're now going to go in again and peel this round. And although this capsulotomy will not be completely circular, it will be centered. And as we'll see, once the lens is in place, it really doesn't look too bad. There's good 360-degree coverage of that intraocular lens. The correct procedure would have been to reapply the dye to get a better coverage. Let's have a look at some of the details for setting up. Here we can see in the operating theatre, there's Capsulaser on the microscope. It's tiny, it doesn't take up significant room. It also means that you can use your operating theatre for different uses. There is multi-use in the operating theatre. On the left we can see a cataract with eye stent surgery viewed on the Ingenuity 3D. And on the right you can do VR surgery with a biome or a Recite or an RUV 800. Here we can see the laser console. And the control module contains a simple user interface by design, two adjustments. The diameter can be set between 4 and 5.5 millimeters in 0.1 millimeter increments. The aiming reticle brightness can be optimized for visualization of the focusing guide. And you can also preset customizable surgeon preferences. Microscope setting recommendations. We recommend saving a Capsulaser surgery profile on the microscope with slower speeds for your XY micromanipulator at 20%, with slower focus speeds also at 20%. And here you can see the Capsulaser foot switch is grouped with the phaco foot switch on the opposite side to the controlled foot switch for the microscope. Once the laser is activated, it completes a 360-degree treatment. Here's the foot switch module. On the left, we've got side switches which toggle on and off the AMET's guidance beam. And on the right, the down switch activates the laser capsulotomy. And you can see the range of cases that have been dealt with, from standard cataract cases to refractive lens exchange, post-RK, pseudoexfoliation, glaucoma, floppy iris, constricted pupil, recessed globes. Soft cell technique is done with Alcon, Viscoat and Capsulvisc. There are detached zonules. We've done intumescent cataracts without any problems with tear-outs, shallow chambers, astigmatism eyes, hyperopic eyes, myopic eyes, mild corneal dystrophy, and even capsules with capsular fibrosis have been treated. So there's a great range that can be dealt with this device. Thank you very much for your attention.